Good day, all, and welcome to the Teledigm Pulse podcast, your Rural Health Matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
All right. Well, welcome to the Teledigm Pulse. Shane, today we have another great guest from our partner Virtuali. We had Angel Bozard on a couple weeks ago. And so we talked a lot about virtual nursing. Today we're going to talk about virtual sitting. Shane, you want to talk about who our guest is and kind of kick us off here?
Well, Andy, excited to have another member of the Virtuali team join us today, and Kristi Fogg, and we're just blessed to have her on the screen. I had to beg though, Andy. I have to tell you, I was just frustrated. I call her and I say, "Hey, is this a possibility?" And she made me beg. I mean,
Okay,
that's just the way this works. But Kristi, so glad to have you with us today to talk about a great topic in virtual patient monitoring. But before we get going on this, I'd like to just have you introduce yourself and tell us a little bit about yourself.
Sure. Yeah. Thanks for having me. My name's Kristi Fogg. I'm the Director of Client Solutions at Virtuali. I am a clinician. I was a registered dietitian. I guess I'm still a registered dietitian, working with kids with congenital heart defects. Did that for a very long time at the Medical University of South Carolina. And took a little step back from the bedside and thinking about what I enjoy and what I love doing. I was very involved with quality improvement efforts at a local and a national level. And I also did a lot of medical research, which I really enjoyed. And so when I was looking for my next step, I found this wonderful company, Virtuali, who was trying to make a big change in healthcare. And I wanted to be part of that and continue to foster some of my strengths in quality improvement and research. So I'm happy to be here. It's obviously a large pivot from nutrition, but with solutions, we're always trying to just solve bigger issues. And specifically with virtual nursing and virtual sitting right now, but where else can we move? Where else can we help? Where else can we partner with health systems? It's right where I want to be.
We're doing a fantastic job, and we're fortunate to have you and Virtuali as a partner in working with our hospital clients and consortiums moving forward. So I'm excited that you're here today. And as Andy referenced, we just did a podcast with the Virtuali team here a couple of weeks ago. So check that out in the virtual nursing podcast.
Episode 33.
33. So check it out. And if you haven't downloaded the podcast, make sure you do so. And leave us some comments. If there's anything out there you want to hear, by all means, let us know. And I know we're going to try and get this done, Kristi, for the paparazzi beats your door down and causes some problems here. But why we're here today is to discuss virtual patient monitoring, which is different, obviously, than virtual nursing. And I think, in some instances, there's some variability or in some cases, it's a little bit ambiguous in terms of how you define virtual patient monitoring. So Kristi, maybe let's start by you just defining in your mind what virtual patient monitoring is.
Yeah, I think when we're trying to describe it to someone, I remember, I guess, describing it to my mom. Let's go there.
Well, this ought to be good.
Yes. Well, people hear this, you do what for a living?
Yeah,
Where
right,
for a living,
sure. Yep.
So health systems, hospitals tag us in to be their second set of eyes and ears, right, into the patient's room. There's a lot that can happen in a blink of an eye, and to have those eyes in the sky and having that camera on your patients to identify some early risks or some risky behaviors, whether that be a patient falling or eloping or at risk of self-harm or harming others. It's just that second set of eyes and safety in the background, ensuring that patients are safe and staff members are safe and patients' families are safe. So I think there's a lot that can layer on beyond that, but in a simple way, that's how I described it to my mom.
Perfect. And it's, and we'll expand on that for sure here shortly, but tell me why why did you get into the virtual monitoring space, and what intrigued you about it that drove you to kind of play from that the more the dietitian side over to let's get involved in virtual remote patient monitoring.
Well, what drew me was Virtuali. Virtuali is an incredible company with an incredible mission and vision, which is to, make moves and make people safe and make people stay in healthcare and make healthcare a little bit safer and more effective, and just be the ally to the people on the boots on the ground who are working tirelessly to take care of our patients. So I think that kind of moved me. And then when I got into the space, I learned more about the services. And I remember my first day on orientation also thinking, like, I worked at Medical University of South Carolina, which is one of our clients. I worked there for a really long time. Do I remember a camera being in the room? Do I remember a camera on a patient? What is really the value add here? And so I'm sitting on orientation and sitting with one of our virtual safety observers who is wonderful. And we were watching one of the ED spaces and watching for behavioral health patients, just mainly self-harm and for prevention of self-harm and prevention of workplace violence. And I saw a patient get violent with a staff member, and our virtual safety observers quickly intervened, and were calling security and calling supplemental staff members to come in the room and to help that poor nurse who's doing her darn best every day to take care of those ED patients. And I thought, man, like, this is it. This matters, and it's something that seems so minimal to just have that kind of second layer of safety in the room. But when you see it impact someone's life and safety like that, I mean, it is, I don't know how we live without it,
Right.
There's just so much that care team members can do when they're caring for their patients. They can't be everywhere at the same time. And this just adds that second layer of safety to keep these patients, from having a poor outcome.
For sure, and I think you hit the nail on the head. I think the genesis of the patient sitting component, so virtual monitoring, aka FKA, formerly known as whatever you want to call it, but the genesis was kind of in the patient sitting corridor, and then the evolution kind of into fall risk reduction. And gosh, it goes so much. It's just so beyond that in terms of the capabilities within the systems today. And you hit the nail on the head, Kristi, on a couple of them. One of which is workforce violence, which is definitely on the rise, and the ability to intervene so much faster. And can you share maybe you kind of shared one, but maybe an example of how the intervention or how just by simply having the ability to just beam into the room or at a minimum, trigger audio into the room, how the individual that's participating in the event knows you're there, and it can intervene even though you're not there in person. You're kind of intervening, right? Because you're making it known, A, I see you, B, I've already called individuals to come help. But can you give an example of a scenario that you've seen that in action, or at least sort of a testimonial, so to speak?
Oh yeah, we have plenty. We try to capture kind of all of our good catches and really celebrate our observers who do great things. So we have a laundry list of them. I will say, with having the car, whether you have a cart in the room or a fixed camera in the room,
Sure.
it's just different than having a one-to-one sitter in place. You don't have that visible reminder of eyes on you. I think sometimes that keeps our behavioral health patients at ease because they don't feel watched as much. They just have a screen that's doesn't have visual indicators that someone's on the other end. So a lot of times patients do let their guard down and they kind of forget that equipment's there and watching. And we tend to see a lot because of that, right? So we've certainly had one of the big monitoring indications that we watch for is drug diversion, where family members are coming in and passing drugs to their loved ones or vice versa. And when you're kind of just like sitting on the periphery, they just forget it's there. So
Right.
we've been able to quickly and without alarm bring light to that and to keep the patient safe and to keep those kind of suspect people out of the room. So I think that's a great example, is where we've been able to intervene there. Or we, we have patients, we have a lot of patients that we watch that have delirium and Alzheimer's and dementia, and, they're sweet, wonderful patients, but sometimes they can get agitated and disoriented and start to, put their hands on a care team member. And by us just being able to come on the screen and say, hey, Nurse X, I noticed that you might be having a little bit difficulty there. Can I get another staff member for you? It gives that patient a second of pause, oop, yep, someone's watching me.
Right.
But then also gives that nurse the ability to be an advocate for that situation. What's going to be the diffusion attempt here? Was that enough? Or do I need to call the charge nurse in, or do I, the nurse, want security in? So it gives them a lifeline to kind of scale up, the interaction to keep them safe. And then a lot of the new technology, which we love, has access to a stat alarm. So if things are really escalating, we can set off that alarm. And sometimes it does give the patient a little bit of pause before they would act further, and hopefully helps kind of diffuse that situation. So
sure.
Definitely has seen to be a lifeline and just a quick way to get people in the room to support staff.
For sure. And I think the ability to just have that extra set of eyes is just, I think of all the experiences I had when I was working clinically myself in critical care or ERs, or, the ER, there's a lot of activity ongoing. This is more on the inpatient side. But I can recall a time where we had a sitter that was in the room, but I walked in and the sitter was sleeping and the patient was sleeping. So there really wasn't a whole lot of watching going on by either party. So I think there is a lot to be said about having that additional set of eyes that goes beyond things like fall risk reduction or telling somebody to get back in bed. There's definitely workforce violence. Let's talk a little bit about, the experience with the technology and your experience in seeing where AI is today and the evolution of AI in this particular space, and maybe shed some light on that from your perspective.
Sure. Yeah. So at Virtual Ally, we are kind of technology agnostic. So we work with multiple technology partners to deliver our service. So we are not technology providers. We partner with other tech companies to provide the people.
Sure.
So we've had, the great benefit to play around in a lot of these different platforms and understand what can be best practice and what works well for our patients. And we've also seen where we are only as good as our technology, right? If that technology is not working, we can't deliver our service safely. So I think even before you talk about AI, if you are like a health system or a hospital investing in this equipment, understanding how that works in a real environment is so important. Is it reliable? If you're a rural hospital with, poor Wi-Fi and you deploy a couple sitting carts, how well are those carts going to work when they're running 24/7? How reliable is that video stream going to be? I think this is one of the technologies versus like virtual nursing, where if you're doing a one-time visit and that call drops, you just reinitiate the call. But in patient observation and monitoring, you can't have it drop. It has to be reliable. So I think before you even talk about AI, the most important thing is finding a reliable way to provide the service. And then once you layer on those bells and whistles like AI, I think it becomes really interesting. There's so much out there that we've seen in like the demo environment where you can see early falls detections, and if a patient's trying to get out of the room and elope, or every month I feel like when I go to a new conference, there's a new layer added on to these platforms, and it's so exciting. But at the end of the day, I think there's so much value in the human behind it. So the way I view AI is this is going to enable us to just do our job a little bit safer, right? Mm-hmm. So, when you're a observer watching we watch around 12 patients. That's kind of our safety cap without AI functions, right? Because at some point you get a little overloaded and like the cognitive burdens there where you're like, who do I look at? Who's in the most trouble? Oh, I'm talking to this care team member. What's going on over here with Mr. Smith? So I think AI is doing great things to have those early indications. So if you are engaging with a patient over on this side of the screen, that it quickly pulls your eyes to this side of the screen. So some kind of visual indicators to keep you like tuned in and really alert to minimal changes before they become big changes with that patient. So I like the idea of enabling humans to be a little bit safer. We still as a company are like evaluating whether it's going to help us watch more patients at the same time. But I think that will come with some validation of the models and just comfort with expanding our reach and expanding our views before we say this is absolutely what's going to make this safer to watch more and more patients at one time.
Sure. I could appreciate that very much because that's not exactly the same tune everybody's singing as it relates to that. As soon as you layer over the AI, Andy, you're going to be able to see 1,000 patients at the same time. And
superhuman strength.
Oh, yeah. So I appreciate that sort of that methodical process that you're bringing to that analysis in using AI. I have seen AI very effective in many situations that you wouldn't have otherwise thought. For example, picking off an HVAC unit that was starting to smoke in the patient room, and I just recognized, that's not normal. What's going on here? So flags are, and then of course the human, that's definitely not normal. So triggers an interaction there. So I think there is so much promise. I was just in a couple meetings here recently within the last week on new AI strategies around that's showing significant promise. But to your point, I think it's the human interaction that really wins the day, and how that immediate audio representation helps. And I don't recall, Kristi, I know there's some data out there about simply an audio response over the speaker will mitigate a certain percentage of patients from getting out of bed. I don't know. It was, do you happen to know what that percentage is? I think it's somewhere around 80% of the time or thereabouts.
With a verbal redirection, it's a little over 50%. Yeah, will be effective.
So I think it's, just having that ability. And to your point, there's so many different aspects. Frankly, I don't think we know them all yet, and all the different aspects where it's really going to help us. But the virtual patient monitoring is definitely a need moving forward from a workforce protection perspective, like it or not, right?
Yeah, it or not.
Unfortunately, we kind of need that.
Well, it's shocking to me. I'm spending a lot of time at hospitals and stuff with my dad, and every time I walk into a new facility, big signs about they won't tolerate violence of any kind and all that. I mean, 5-10 years ago, you didn't see those kind of signs. So things have changed. And this is more necessary now.
Yeah. And some very unique AI components too. In fact, predicting when somebody's going to get violent or arm gestures they're currently in the process of doing that is predicting violence. So some fascinating stuff. Back to the reliability of the equipment, the technology. And I can't agree with you more, Kristi. It's no different than any of our other 50 plus service lines. The stuff has to work at the end of the day. And I sort of described this. I was just presenting here a couple of days ago, and I said, it's sort of like, you go to the car dealer and you buy this car, it massages your back. It's got AI and it talks to you, it drives you around, it sings whatever song you want, and it makes you a sandwich on the side. And I mean, it is the real deal, right?
Yep.
And you're on the way to work, and all of a sudden the car just dies. And it's just got all these fancy things, but the car's dead, and it can't do the basic function of I just got to get to work, right? Instead, I'm sitting on the side of the road, but I got all this fancy stuff with it, and so I can't agree more. And to your point, I think, and I got to tell you, I think this is often underestimated in facilities that are looking at this type of solution to really do their due diligence on analyzing just that this is a 24/7 constant stream that cannot be broken.
Right.
Because you hear some of the horror stories with certain situations, not virtuality per se, but where, a sitter has, there's Andy in bed. Andy looks like he's resting comfortably, but Andy's actually at the bar. But Andy from the virtual sitter side looks like he's doing just fine, but he's already eloped and Gandhi. So, how do we, and again, that just gets back to ensuring the reliability of the system. And this is significant for a variety of things. And so, and then understanding the technology, alerting you to, hey, something's wrong with the stream here, based on intra video analysis on what's going on with the stream. So it is critical for sure in this environment. And I think it's often, because you don't think of it as a physician beaming in. And that's an episodic event. That's not a continuous event. So I think it's sometimes it's marginalized almost in terms of the need to ensure the reliability and the tech side of the equation. So I appreciate your thoughts on that, Kristi, for sure. How about in terms of the future in virtual patient monitoring? Do you have a sense of other applications? Obviously, we've talked a lot about hospital inpatient activity. And I would like to bend you a little bit more on, there's a lot of dialogue around, some other applications. And this has been used in this, but how I guess, let me back up a second here. Let's go back to typical use cases, but maybe further delineate the behavioral health side of the equation and suicidal ideation patients. When do you recommend it? When do you not recommend it? Who can you use it for? Do you do it in behavioral health facilities or psychiatric facilities? And in what capacity?
Sure. So I would say we're pretty evenly split. Like on our populations, we watch a large amount of behavioral health patients in the emergency departments, in psychiatric institutes, and then like just behavioral medicine units. I would say the big thing is we do watch to like fulfill that sitter requirement. So if a patient has like low or moderate suicidal risk, we can watch those patients. It's still exempt in the high risk patient because they need a one-to-one resource, which is totally understandable. But we also watch like patients with eating disorders who need to be observed during their meals and just coached. It's not just observation, right? We're here to reassure them and let them know everything's okay. And do you need a staff member? Do you need this? We're there to, be compassionate as well. Right. We watch patients, of course, when we feel like care team members are at risk. We watch a lot of patients for questionable social situations. I come from a pediatric background. We've all had those patients where we're like, what's happening in that room after we leave the room, right? So we can watch for kind of the social environment as well. So there's really no limit there as long as we feel like we can keep them safe virtually. I think where we are smart as a company is we draw our limits of like, we've put this patient on a 1 to 2 hour trial of virtual monitoring, and we don't feel like we can be effective enough to keep them safe. Like in the case of like someone with homicidal ideation, that's truly a little more aggressive, or someone that's requiring like hard restraints, that we just feel like a one-to-one resource is a better option. So I think it's always worth trying, because some of the patients that do really well on virtual monitoring might surprise you. We will get calls and just, oh, this patient's really confused. Maybe they have schizophrenia. I'm worried that if you're talking to them through a screen or a microphone, that this might confuse them. But then after we interact with them, they're really liking it. And they kind of like having someone to talk to in the room too at their call, because they can wave and get a hold of us. So I think it's always worth trying it on those behavioral health patients and seeing the impact we have. And we know from the data that we keep that we're making an impact with these patients. We're able to reduce one-to-one sitter hours. We're able to reduce restraints. And we're able to keep patients safe and reduce self-harm and staff harm rates. So I think it's just a matter of making sure it aligns with your institutional policies, but they're a great population to work with, and it extends your workforce, not having to only watch one patient per person.
For sure. Yeah, I can just see tons of applications here. In fact, do you have, I could even see situations that are requiring one-to-one, right? A person in the room. But I could see situations where you'd have this on top of the one-to-one,
Exactly.
just because you're just adding yet another set of eyes. Because stuff could go down there despite the one-to-one.
Absolutely.
For sure. So I think there's tons of applications there. Yeah, that's great information. What about patient adoption? Do you find that you get a lot of pushback from patients that are nervous about having the camera? And I know many facilities have built this into more of a conditions of participation as part of their signing, to be an inpatient in said facility. But what's your sense on the number of patients that push back on this, or family members that push back? Or, do you get the sense of, of course, if you have a family member that's wanting a camera turned off, do you kind of wonder why they want it turned off, I suppose. But what are your thoughts on that?
I think that's definitely that's part of that. We don't typically have patients refuse it. And again, it's usually baked into the treatment consent that this is just per protocol and this is part of your care. So we don't get a lot of pushback there. But I think there's something to it not being a physical person that feels a little less invasive, because it's your face isn't on the screen all the time. Our face just comes on the screen when we're there to engage with them. So it feels a little more minimally invasive than having a person in your room. So we feel that it's like pretty well adopted. And you're right, a lot of the families that don't want us in there need us in there. But for our medical patients who are watching for like falls and confusion, their families are really reassured by it. My father has pretty advanced dementia, and I remember explaining this to my mother, and she said, when do we get one at home? So, having some reassurance that someone's there. If I look, it's not just, that patient's getting up to fall. It's like, that patient that I've been watching all day looks uncomfortable. They're moving a little bit differently than they've been moving. Something's not right. Let me talk to them. Let me reassure them. Let me see what they need. Oh, you're in a little bit more pain than you were this morning. Let me get your nurse in there. So it's just giving an extra layer of like reassurance that care is going to be more focused, and that we can have some early indications that something's awry. And it gives family members a little bit more reassurance that their family members getting extra care, like, oh, okay, I'm going to go home and take a shower. I'm going to go home and sleep at home because I know that my loved one's safe in the hospital with an extra pair of eyes on them.
Yeah.
Yeah, for sure. I think of many situations where this could have been helpful.
Oh, absolutely.
For a lot of facilities. When it comes to we've talked a lot about of applicability in different situations. Tell me about when you're working with a hospital and they're debating, right? They're debating, do I put this in? And let's just say that they've come to the conclusion, we think this could make a difference. And Kristi, I'm going to put you on the spot here, but let's just say that the CFO in that particular institution says, this is just going to be too expensive. We're just not going to do this. I don't think we can afford this right now. What are typical things you go down, the roads you go down when you start to have these conversations when it comes to return on their investment? What are things they should consider as part of a return on investment strategy or a value proposition, if you will, as a part of a remote patient monitoring system?
Sure. Yeah. I mean, I think the ROI argument in monitoring is a little bit easier than in nursing. Because as soon as you replace a one-to-one sitter with a virtual monitor, it kind of pays itself off. So I think the workforce reduction of not needing as many one-to-one sitters is a great financial benefit, but we know that this is effective in reducing falls. I mean, we've seen it personally with our own clients being able to reduce falls by 50 to 75% and greatly reducing falls with injuries. And think about how much that cost to a facility, and to our patients. So falls reductions, restraint reductions, one-to-one sitter reduction. I mean, they're easily seen and well documented. And I think an easier argument for sure to that CFO.
Yeah, can't agree more. And frankly, depending on the size of the institution, it is It's a no-brainer, really. I mean, it really is. And now I say that loosely because, and the reason I say that loosely is you will run into institutions that have tried to deploy something like this, and it didn't go well for whatever reason. And most of the time, it comes down to a service failure or a technology failure. And I can't give you the percentages which has been more than the others, but I've seen both and complaints on both sides. But I do think those programs that have gone well, the ROI proposition is extremely strong across the board, and arguably one of the best ROIs, again, particularly for the larger institutions. But we do have an interest in moving this out aggressively as a service offering into some of the smaller markets, which is a newer concept to a lot of the smaller markets. So, Kristi, can you give me some thoughts around how we've talked a lot about various components where you see this being helpful and being used, being applicable. Now, let's take a little bit smaller facility. And let's say they're carrying an average patient census of, let's say, 7 or 8 or 10 or so, somewhere in there. So we'll just say critical access hospital size. And, the ROI proposition on them is going to be a little bit different. But I think the beauty of what we're trying to do or accomplish is to build all this into a single platform and system so that it's simply layered in. You can get access to this. But beyond what you've already mentioned, can you think of in the smaller facilities any benefits to them that maybe they may be overlooking as part of because most of the time in the smaller markets, they don't come to us saying, hey, we want to do remote patient monitoring. We think that'd be great. It's usually there's another program that's being deployed there that then the suggestion about using patient monitoring comes up. And I think the behavioral health side of the equation is a great one.
Oh, yeah.
But what are your thoughts on that in terms of encouraging people in smaller markets, or maybe you've seen in some of the smaller markets, some of the similar benefits that you're seeing in some of the large markets?
I think, well, the first point you brought up is really important that, when you're investing in this technology, I think one thing that they're doing a lot of things right, but technology providers are starting to think about how can this platform do multiple things. So you're not just investing in this sitter application when you're only going to use it on 7 patients. So I think that's great when you have multi-purpose from your technology, and sitting is just a layer of that, or virtual monitoring or observation is just a layer of that. I think beyond the obvious one-to-one sitter need for behavioral health indications or falls or device manipulation or just reorientation of patients, there's like this layer of just environmental assessment that we do of like, this patient's going to fall because you just put their tray in there and it's this far away from them, and the bed, the side rail's not up, and they don't have their grip socks on, and it's kind of like reinforcing their safety bundles. So that's something that we offer quite a bit, is just being intuitive to what their environment is doing, and reminding, those newer bedside care teams or those busy bedside care teams that are running all over the place, what other layers they have to put in place for those patients on the ground. So I think being your partner in quality and safety is something that we do really well. Obviously I'm always going to advocate for a third-party service provider because I know we're great at our job. But if you are a smaller hospital who belongs to, a network of hospitals or a partnership with other hospitals, when you have a virtual observation like hub, those hubs can serve multiple hospitals at once. So if you only have 3-4 patients that might qualify for this layer of safety and observation, whether it be for falls reduction or behavioral health or what have you, it could kind of like leverage that network of who we provide service for and make it a little bit more obtainable than you as the hospital having to designate a resource to do 24/7 observation. So I think that's where you can see a little bit of cost savings using a staffing partner that can expand your reach a little bit.
For sure. And honestly, we're doing that across all different disciplines and specialties,
Yep.
and virtual nursing is no different. It's hard proposition to suggest, you need to hire 5.5 FTEs worth of nurses to do your remote nursing program when you're like, you can use it for 30, 40, 100 hours a month kind of a thing. So you're spot on with that, Kristi. I think, and again, I think the fall risk reduction is a great one on multiple fronts in terms of falls. And I think one of the challenges in the smaller markets is the numbers in some cases are so low to not be reportable. And I think the falls in general may be a little bit underestimated, but certainly as when they start to deploy our programs and have more and more patients in their facility, in some cases sicker patients in their facility, this becomes more important as an adjunct and a tool to bring that all together in one platform or one offering, if you will. But I do think there are, to your point earlier, and I hadn't really thought of this though, but Chris, you make a great point in terms of we can predict somebody getting out of bed and falling with AI assistance and subtle movements that the body's moving. But here's the deal. You're spot on. If you put the tray in a spot that's going to increase the likelihood of them falling, well, gosh, it's worth a call to say, hey, we need to move that tray closer to the table. Or they don't have their grip socks on, or they don't have, their SCDs are still, or whatever the case may be. That there's a lot of factors there that could preventable things. So really what you're doing beyond sort of the prediction of whether or not somebody's going to get out of bed, but rather preemptively addressing some issues that are clearly a risk factor for falls.
Oh, yeah.
Right?
Yeah. And to your point, too, if the hospital's starting to keep sicker patients than they're accustomed to, that's also going to be a higher risk. So the preemptive work is really important.
And I think the behavioral health side, on hospitals that are struggling to transfer out their behavioral health patients because the psych beds are full, despite us having psychiatric services that can be deployed there, I think there are situations where they have to keep behavioral health patients there for an inordinately long amount of time, right? And so that being said, and we all know that the providers are uncomfortable with that. A lot of times the nursing staff's uncomfortable with that. And there's some cases some pain associated with retaining those patients for extended period of time, that this could be another great solution to help with that process in terms of ensuring safety and also just keeping another set of eyes on those behavioral health patients that you have to just keep indefinitely until you can find a bed that's open. So I think it's a great option there too.
Yep, for sure.
And you brought up a point earlier about like layering in services, but we are seeing so many hospitals too building in like deterioration detection and using this in higher acuity patients. We had a great win the other day where a patient looked just very painful and was having difficulty breathing, and we were reaching out to the team and they were able to quickly call a rapid. And it's also just like being able to quickly recognize symptoms of deterioration so that you can help prevent escalation of care. And I think that's sometimes where we can tag in virtual, like when you have virtual nursing and virtual observation in tandem, because our observers are kind of like a patient care technician, nursing assistant level training, but being able to tag in a nurse to come in and quickly assess them because you've noticed something in the room that's concerning is really being able to leverage those two, or a virtual provider. If a nurse is watching multiple patients and watching for deterioration, they could beam in the provider as well. So it's just a peace of mind application for me, for sure.
Oh, certainly. Well, listen, Kristi, I so appreciate your time today, and again, I can't thank you enough for joining us today. I think this has been some great information as it relates to patient monitoring, and I can't agree more on all your thoughts and your points, and I'm excited to continue this relationship and really see where this goes in the future, particularly in the rural markets. And really helping to facilitate a comprehensive solution for them. And I think this is an important part of it.
Absolutely.
Well, thanks for having me.
Yeah, thanks for coming on.
Hey, Kristi, thanks so much again for coming on, okay? We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledigmhealth.com. That's pulse@teledigm health.com. For more information or general inquiries, please visit teledigmhealth.com.